All right, everyone ready to go? Yes, no? I'll assume silence is a yes. Let's go with that. I apologize for being late. It is, the traffic was awful from going on to I-4, which I'm sure anyone here can commiserate with. So, anywho, going on, we were talking about our anticoagulant drugs, right? We talked about our heparins, we talked about fondaparinux, we talked about, what else we talked about? Like Lovenox, like low molecular weight heparins, right? So now we're getting into some other ways we can affect the system. Because if you remember, heparin was sort of the least specific in terms of what it was affecting, right? It was like 2, 10, 9, 11, and 12 as the factors it was inhibiting. And how did heparin work? Anyone remember? It does stop the coagulation cascade by doing what? Good. It helps to facilitate antithrombin 3 to work that much fast, like 1,000-fold faster, right? So very good at what it does. Remember, as you get shorter and shorter molecules, it gets more specific for which factor? 10 as you go on, right? So fondaparinux is going to be 10, a lot of 10 and a little bit of 2 activity. I'm sorry, Lovenox, like low molecular weight heparins, are mostly going to be 10, a little bit of 2, and then you get into fondaparinux, specifically just going to be what? Just 10, good. So remember your monitoring parameters change for that. So for instance, with normal unfractionated heparin, what would you use to monitor that? APTT, good. And then when you get into something like, say, enoxaparin or fondaparinux, you use what? Anti-10A, right? So again, that's going to be more specific for that activity there. Remember, things like Lovenox are not going to be affecting your APTT. So if you measure that level, it's not going to do any good because it's not going to be, not to correlate to anything. So focusing on the other side of things, instead of affecting factor 10, and with like heparin and like your low molecular weight heparins and fondaparinux, those have all been parenteral so far, right? So those are all going to be agents using either the IV sub-Q route here. We're going to go along that similar vein, and I'll mention when we get into our oral anticoagulants. That's another important class for like long-term management. But now we have our direct thrombin inhibitor. So this is affecting factor 2. Remember, thrombin is just another name for factor 2. And this is actually very interesting based off of Hirudin, which is the anticoagulant that leeches produce. So back in the olden days, and actually still to this day, we actually use leeches in some cases for its anticoagulant effects. And so actually we just had a case, my wife, who was also a pharmacist, one of her pharmacist friends sent her a picture of a patient who was actually on leeches. I guess he had some sort of like scrotal edema that was happening there, and they actually applied leeches and was able to take that down. So again, interesting uses for leeches there. But based off of this Hirudin that they produce, we have a couple of drugs that fit into this category. So we have things like lepirudin, bivalirudin, and argatroban. These are all going to be used basically as an alternative to something like heparin. So say if you had a patient with a history of HIT, or maybe they developed HIT, this is a good alternative anticoagulant you could put them on in order to keep them anticoagulated. Note here you're still using APTT, which makes sense because you're affecting factor 2, right? And just be aware in some cases here, things like renal function is going to matter. So if patients were having renal dysfunction, lepirudin might not be a good choice. Maybe argatroban would be a better option. Or they have hepatic instability, maybe switching over from argatroban to bivalirudin makes sense there. And some of this is going to be dependent on the hospital formulary and what you've got to work with. Now, getting into our oral anticoagulants, next we have warfarin. I'm sure most people have heard of warfarin or Coumadin at some point in their careers here. For a long time, this is all we had in terms of oral anticoagulants. This was like the only game in town, and that did provide some problems because there's a lot of issues with using warfarin. In fact, there's whole pharmacy groups that just do warfarin monitoring. That's all they did. And in fact, I think 3 months out of my 12 months of rotations, I was working in a Coumadin clinic, at least in some capacity. So it was a big deal, and that's what we had to do quite a bit of. But anyway, so warfarin is actually an acronym. Yeah, again, if you ever want to impress your friends with your knowledge of pharmacy tips, it stands for the Wisconsin Alumni Research Foundation. Again, some of these things are more interesting than others. But anyway, we found that that warfarin and other sort of derivatives of warfarin, actually we use it as rodenticides. You know why? And rodenticide means what? Kills off rodents, right? And so it's actually interesting because we can give this to rodents. They actually don't have a vomiting reflex, and so once they eat this stuff, they get anticoagulated. They basically bleed out and then desiccate. So that's how we use them for rat poison. But does the same thing as a warfarin that you would give a typical patient with, say, for instance, AFib. Now, why would a patient with AFib need warfarin? Right, so as that atria is just sitting there just kind of quivering, not really doing its job very efficiently, it's going to sit there and blood can pool and can form clots there, right? And so what's the primary thing we worry about in a patient with AFib who throws one of those clots? Stroke, right? Because again, the first place from the left side of the heart that's going to be hitting is what? The brain potentially, right? So that's what we're worried about there. And why patients who with AFib, even though it's in a cardiac dysrhythmia, are on long-term anticoagulation. Anyway, so the way that this drug is going to be working is it's a vitamin K antagonist. Okay, is vitamin K a fat-soluble or water-soluble vitamin? Fat-soluble, right? What's our other 3 fat-soluble vitamins? A, D, E, and K, right? Good. So basically what this is going to do, now whereas something like heparin was working on already formed active clotting factors, warfarin is going to work on basically the production of clotting factors. Okay, so this means it's going to be working within the liver, and it's going to be preventing this recycling of vitamin K that you can see here. Basically, vitamin K normally gets recycled in the production of a lot of these clotting factors. 2, 7, 9, and 10 are some of the big ones that are going to be affected here, along with a couple of different proteins called C and S, essentially. And so by inhibiting this recycling of vitamin K, you're going to then decrease the production of these clotting factors. So what do you think this means in terms of the onset of action? Is warfarin a very fast-acting drug, or does it take a while? It's slow. Why is it slow?
Depends on vitamin K.
It will depend somewhat on vitamin K, but what more specifically? Exactly. You have to get rid of the active clotting factors already circulating in the blood. So you can't just give someone warfarin immediately and expect them to be anticoagulated. And in fact, in some cases, it can actually make them more procoagulable, as I'll show you in just a moment here. But again, if you're just knowing as far as the mechanism goes, it's a vitamin K antagonist preventing clotting factor production. Just another picture kind of showing you the same thing. Again, this is the enzyme that's being inhibited here, is vitamin K oxide reductase. One thing to note is that you have 2 different enantiomers of warfarin. When I say enantiomer, what does that mean? There's a left-sided and right-sided version of it, right? And so these actually have different clinical impacts because the S form of warfarin, the left side, the sinister side, so to speak, is the more active form. And so this is going to be primarily metabolized by CYP2C9. So this will be important for certain drug interactions we'll mention in a few moments. And then the R enantiomer of warfarin is going to be through like 1A2, 3A4. And so we know there's several different drug interactions that are already going to come about just from this, right? But typically ones that affect 2C9 are going to be more clinically significant than you'll see with, say, anything affecting the R enantiomer of warfarin, just because the S enantiomer is more active. Anyway, so what you're going to find is that this has no effects on already existing clotting factors in the blood. It's only going to work on the production of new clotting factors, which means it could take between 2 and 3 days before you really see full anticoagulant effects from this drug. So what does that mean for someone, say for instance, they come in and you have, say, again, I always think about like the young woman that comes in, has a history of being on birth control, and she's a smoker, and all of a sudden she's got chest pain. You're thinking, PE, right? So again, this is not a person you just put on warfarin and say, all right, go on your way and be well. You have to put them on other anticoagulation first in order to deal with that clot that's already there, and then we'll have what they call bridging therapy. You know what that means when I say bridging? Basically, I'll start them on an anticoagulant like heparin, and then I'll also start maybe warfarin. Once they get stabilized, I'll start them on warfarin, and then they'll be on 2 anticoagulants at the same time. And wait a second, like they're going to bleed out, but not really because the warfarin hasn't really kicked in yet. So you keep them on warfarin until the warfarin's working, and then you stop the heparin, and then at that point they're anticoagulated just from that warfarin standpoint. Because again, a lot of patients like that who have a reversible cause may still need to be on anticoagulation for a couple of months, depending on the indication there. But again, this when I say bridging therapy with warfarin, that's what I'm talking about because of the delay in onset of effect. Now, and again, it depends on the factors and how long their half-lives are in terms of when this anticoagulation kicks in. And note here that things like protein C is actually going to be an anticoagulant. And this has one of the shortest half-lives here. It's going to be able to run out pretty quickly, which actually means if I were to, say, have a patient who came in with that PE and I start them on warfarin alone, you'd actually put them in a more procoagulable state and you could worsen that PE. So this is why we have to have that bridging therapy to make sure they're well anticoagulated and then put them on the warfarin, bridge them until they're therapeutic, and then get them off of the other anticoagulant at that point. Okay, so just know they can be hypercoagulable very early on and then before the actual full anticoagulant effects kick in. So this is given orally. So again, this is why it was so popular, is because it was the only orally bioavailable anticoagulant we had for a really long period of time. It also had, a good long half-life, so it stuck around in the system for a while. Even if they missed a dose, you wouldn't necessarily see a big drop in the monitoring parameters we'll talk about here. But there was a lot of big issues with it. It's 99% bound to albumin. What does that mean in terms of drug interactions? What if I have another drug that likes to bind to albumin? They can kick it off of the protein. What does that do to my active fraction of drug? It can go up, right? Because the more free drug, the more active it is. So if I say I had a drug interaction that knocked the protein-bound warfarin from 99% down to 98%, is that a big deal? Yeah, because that doubles the active free form of warfarin that's available to the blood. So that can be a big deal, right? Because you have more drug there that's available to interact with the liver. Other things, like I mentioned, the drug interactions in terms of CYP interactions is going to be a big deal. We'll talk about a little bit later on there. And then just know that these are not going to be used in pregnancy. Anytime you monkey around with fat-soluble vitamins, it can be teratogenic. What other fat-soluble vitamin have we seen drugs affect that we said was contraindicated in pregnancy? Vitamin A, right? Specifically which class of drugs? Our retinoids, right? Remember isotretinoin, we talked about how that affects vitamin A, and that is certainly teratogenic. There's a whole REMS program that has to be get put on. So again, you would find that and again, when you're pregnant, are you hypercoagulable? All those estrogens surging through your system? Absolutely, right? So this is something where patients may have to be on warfarin for the duration of pregnancy rather than something like warfarin.
So what other drug examples interact with albumin?
So for instance, like there's an antiepileptic we'll talk about next semester called phenytoin. There's also highly protein bound that can disrupt that. Certain natural products your body produces can bind or can kind of go for those same sites of binding. So it just depends on the clinical situation. Anyway, so things are going to decrease the actions of warfarin. Things are going to make it work less well. So if I have anything affecting vitamin K, meaning if I have more vitamin K coming in, that means I can use that vitamin K initially to produce new clotting factors. I just can't recycle it. So for instance, where do I get a lot of vitamin K? Green leafy vegetables. So kale, your spinach, what else? Brussels sprouts has a lot in there. Anything else? Collard greens, absolutely, right. So, and again, like the first place I did my community rotation for my first rotation in school, and I was basically working at a warfarin clinic in Palaca, Florida. Anyone know Palaca, Florida? It is real podunk. I live like 20 minutes outside of Palaca, if that gives you any clue as to my background. But basically, I was there for 2 months doing this Coumadin clinic, and it's like these are people that are very much like salt of the earth, kind of just they produce a lot of their own food that they eat. They grow a lot of their own collard greens and spinach and stuff like that. So they eat a ton of food with vitamin K, which made it difficult to get the warfarin dose right. Because one of the things you're going to see is that when you have patients on warfarin, you don't want to say, well, don't have any vitamin K, because then you're going to find the drug works too well. But you got to be consistent with it, right? So you can't just have a patient say, I'm going to go into all spinach diet all of a sudden, because that's going to make the warfarin not work very well, because there's so much vitamin K coming in, they can produce a lot of new clotting factors. Similarly, if they eat a lot of spinach or collard greens or whatever on a routine day-to-day basis, you don't want them to stop eating it all of a sudden, because you're going to have the opposite effect, and the drug's going to work too well, and they could have a bleed. These are things you want to be careful of, right? Other things that are really important. What's another really important source for vitamin K intake into our system? The bacteria in our gut. They process a lot of that vitamin K that we then absorb. So if you have, and what are some ways we could disrupt that normal gut flora? Antibiotics, right? This is why you see a lot of those drug interactions between antibiotics and warfarin, is because if it affects the normal gut flora, you're going to find to get rid of some of that bacteria, then we don't absorb as much vitamin K. So that's going to be another interaction we'll talk about in just a few moments here. So anyway, so other things that can affect this. So for instance, if I'm having, say, agents that are altering CYP2C9 activation. So for instance, anyone know any good CYP2C9 inhibitors? So one really good example from the antibiotics be Bactrim. Bactrim is a strong CYP2C9 inhibitor, that's sulfamethoxazole and trimethoprim. You gotta be really careful and never mix warfarin with Bactrim, or at least make sure you're adjusting the dose of warfarin down, because that's going to cause a heck of a lot more anticoagulant action out of warfarin there. Be really, really careful there. We talked about protein binding interactions. We mentioned liver function. So if you have poor liver function, you're already not going to produce enough clotting factors anyway. And in fact, when you think about monitoring liver function, what do you order? Which stands for Liver function test, right? So it should presumably tell you how well the liver's functioning, right? You get your AST and your ALTs and things like that. That's actually not the best sign of determining how well the liver's actually functioning. A better way to do it is to monitor the INR, which we're going to talk about in a second here, is how you monitor warfarin effects. So for instance, if I have a patient who overdoses on Tylenol, we talked about Tylenol before, and what's the main organ toxicity we see with Tylenol overdose? Liver toxicity, right? So I can have a patient who's coming in with a Tylenol overdose, and maybe their LFTs have started to bump, maybe their AST, LT is like in the hundreds. Their liver can still be functioning and still working. When their PT-INR starts to go up, that tells me they're not producing clotting factors anymore. That's a very bad sign, because that shows me the actual function of the liver has now diminished. Anyway, so you gotta be really careful with this drug here. The way that we actually monitor that, as I mentioned, is PT-INR. Now, we like to use INR, it stands for International Normalized Ratio, and this makes it so that even though different labs may have different kits, you can compare them apples to apples, so to speak. So if I get a lab done, I get a PT-INR done at Advent Health, and then I go get one done at Nemours, they are directly comparable to one another there, right? So it doesn't matter where you get it measured at. Anyway, so what's a good, what's a normal INR for patients who are not on warfarin? 1. So presumably, if none of you are on warfarin, all your INR is 1, because it's a ratio of the patient's PT to the reference PT. Okay, that's why it's called a ratio. So if it's normal, it's considered 1 at that point. Now, to anticoagulate someone with warfarin, what do we like to get them up to? Anyone know? 2 to 3, right, is the most common INR you'd be shooting for. There are some cases where your patients are more hypercoagulable, and you would put them on a higher INR goal, right? Anyone know those cases where you do that? There's like one really clear example, and that's going to be if they have a mechanical heart valve. Again, anytime you put a foreign material into the body, especially like a metal mechanical heart valve, they are much more likely to clot off, because stuff like that just bind to it and clot to it. And so in those cases there, we shoot for a higher INR goal, 2.5 to 3.5, and that way they're going to be less likely to have a clot due to that. That's only with a mechanical heart valve. Okay. So again, you have to be really careful. As I mentioned, some patients will also have just an innate sort of warfarin resistance. So for instance, they can have mutations in their, say, CYP2C9 enzymes. They can have mutations in their vitamin K processing enzyme, such that they may be more susceptible to warfarin, or they may be more resistant to it. I've had some cases too, as I mentioned with the CYP interactions. One of the things you'll find is that we'll talk about HIV next semester, but a lot of the HIV drugs, they inhibit CYP3A4 pretty strongly, and we actually use that to our benefit to make it so that we boost levels of other HIV drugs. That way we actually have to dose it less frequently. I had one patient who was on warfarin for AFib, and he also had Hep C and HIV, so he's on a bunch of these drugs that inhibited CYP2C9, I'm sorry, 3A4 specifically, and so he was very sensitive to changes in his warfarin dose. You see his INR kind of go all over the place, and so it made it very intensive in order to do a good monitoring for those patients. So basically what you're going to find though is that you'd have a patient, you start on warfarin, you give them a couple of days, and then you go back and check an INR, and then based on the INR, if it's too low, what do you do to your dose of warfarin? You would increase it to try to get your INR up, and then if it comes back too high, then you would presumably decrease the dose. And so patients will come back and say a couple of days, check INR. If it's in range, and you bring them back in another week, check another INR, make sure they're still good, and then you can start to space it out from there. Or if it's out of range, then you have to adjust it based off of their diet and things like that. And so what do you think this means in terms of patient compliance? It's not great, because they have to keep coming back in. I had that one patient who had, she had a hypercoagulable genetic predisposition to where she was coming back in every week for the entire 8 weeks that I was at that rotation site, because she just could not get her INR under control, because she was taking it like she should have. It was just this fact that she's genetically predisposed to not processing that warfarin well, and was very sensitive to it. And so you have to be really careful with those patients. And so that's a big reason why we were looking for newer drugs to kind of supplant warfarin, because it was such a bear in terms of monitoring parameters, in terms of having patients come back so frequently. But we'll see there's some benefits to warfarin as well in just a moment here. Now, biggest toxicity, just like with the other anticoagulants, is what? Bleeding, right? Bleeding is a big deal. Typically, you're going to see that if they keep their INR within a therapeutic range, then chances are they're not going to have too many problems with that. Maybe some easier bruising, maybe some, TKI here and there, but for the most part, you're going to find bleeding is not going to be a big concern if they're within range. However, what happens if you have an elderly patient who maybe is in the tub and then they take a slip and fall? They can have a head bleed pretty easily, right? So it's very, very common that you have these patients who will come in after falling in the shower, have a huge hematoma on their head, and they're also on warfarin. That makes total sense why that is. Once they start to get the INR, say going above 4 or certainly above 5, that's where we worry more about clinically significant bleeds, head bleeds, GI bleeds. I mean, you can bleed anywhere basically with warfarin on board. And the question is, well, how would I fix that, right? So for instance, if I had someone who had too much heparin on board, what do I give them to reverse that? I give them protamine, right? Remember, I can't just give fresh frozen plasma to someone on heparin because the heparin is going to inactivate that, right? So it doesn't really make a whole lot of sense to do that. However, with warfarin, though, what can I do to reverse those effects? Well, one, I can replace the vitamin K that's not being being recycled in their liver, so I can give them vitamin K. That's an easy way to go ahead and get that process started. Do you think that's a quick fix or a slower fix? Why slower? Still got to produce those clotting factors, right? So there's a delay in onset. What if I have a patient who's bleeding right now, come in for altered mental status, and you get that head CT, and it comes back, and there's just a big fat head bleed going on there? What can I do to fix that immediately? Fresh frozen plasma, right? So FFP is what I'm going to give in those cases there, because why? That has all the factors in it, right? So it has all the clotting factors already in the plasma, so I'm going to give them that, and that's going to go ahead and kind of reverse the effects of that warfarin very quickly. Okay, so those are the ways we're going to treat that. So it's good to know the interaction, or good to know the ways we can reverse the effects if there is one available. Because again, if you have a patient who comes into the ER and they have a major bleed, you want to know how to fix that pretty quickly. Okay. Anyway, so again, cause a lot of birth defects. That's why we don't give it to pregnant patients. And you can see some skin necrosis that occurs more often in patients who have maybe a protein C or S deficiency. So as I mentioned, warfarin is highly diet dependent. It is requiring frequent monitoring. There's a ton of drug interactions, but the big benefit is it is easily reversible. So if you have that older patient comes in falling in the tub, they have a big hematoma, you can fix that pretty quickly with FFP and vitamin K. But we were looking for alternatives, right? So for instance, with a pretty high risk elderly patient, warfarin may be a good option for them. However, as I mentioned, that younger lady coming in with the birth control and the smoking, and she has a PE, and she needs to be on anticoagulation for a couple of months, is warfarin a good option for her? She has to go to school, she has work she has to go to, it's not great from that standpoint. So we needed newer drugs that did not require as much monitoring. And so this is where we have some nomenclature called them the NOACs, the new oral anticoagulants. Some people call them the DOACs, which would be the, I don't know what that stands for. Most people call them the NOACs nowadays, but they use DOAC for a short period of time. But anyway, I'm sorry, direct oral anticoagulant is what that DOAC stands for. Anywho, so the first one we had on the market was called Digoxin or Pradaxa, and so this one was a direct thrombin inhibitor, and so this is kind of similar in action to something like bivalirudin or lepirudin, but now we have an orally bioavailable one here, which is again good for outpatient chronic use here. And so again, by preventing the activation of fibrinogen, it then had downstream effects to kind of prevent activation of a lot of the other bits of the clotting cascade. And so you could use this for DVTs, you could use it for PEs, AFib. It was great because there's no routine monitoring you had to do for it. So you just put them on a standard dose and then they're good to go. You don't have to do any further monitoring. Certainly have them watch for things like signs and symptoms of bleeding, but for the most part, they're good to go. The problem though is that there wasn't a really good available antidote, and actually there is now, but it's kind of a late sort of comer here. And so what's actually interesting is that the same company who produces Digoxin actually ended up developing a monoclonal antibody that was designed specifically to bind up that Digoxin and neutralize it. So again, not only to get money off of selling the drug itself, but also you get to sell the reversal agent too, so it's kind of smart there. However, what is the problems with monoclonal antibodies? Are they cheap drugs? They're expensive. Is vitamin K cheap or expensive, you think? Cheap, 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 right? So again, looking at the cost associated with this, not every hospital is going to carry the monoclonal antibody to neutralize Digoxin. It's called idarucizumab or Praxbind is the brand name. But certainly every hospital you should be able to find some vitamin K for sure, right? In some cases though, you do have to watch for dosing for renal function, so you would want to be more careful in patients who have a history of that renal dysfunction there. Okay. Some other ones we have includes rivaroxaban or Xarelto. So instead of working on factor 2, this one's actually going to be affecting factor 10A. Right, so this is sort of an oral alternative to something like fondaparinux, where it only works on factor 10A. Similar indications to Digoxin. This one, again, not a really easily available reversal agent here. So if I had an elderly patient who had that slip and fall and they have a big head bleed, there's not a whole lot you can do for it, unfortunately. There's some things called prothrombin complex concentrates, which is basically a super concentrated form of prothrombin complex of different factors. You can give that and you'll have some reversibility, but again, it's not as efficient as something like vitamin K would be for something like warfarin, right? And then you have apixaban or Eliquis. I'm seeing a lot of patients being put on this nowadays. Again, it's another oral 10A inhibitor, very similar in actions to rivaroxaban. Just note here that this one is metabolized by CYP3A4, so you do want to watch out for that interaction, right? So that's something that maybe rivaroxaban has a leg up on apixaban because it does not have that same 3A4 substrate activity, right? Okay, so that's it for the anticoagulants. Any questions on those? What's interesting, you're actually starting to see a lot of patients nowadays. Traditionally, if you had a DVT or PE, you'd come into the hospital, you get put on heparin drip, and then you'd get transitioned over to warfarin. You'd be on that for several months to many years, depending on the case. Nowadays, we're actually starting to see some evidence. You can just have a patient who comes in with a PE, DVT, you can just start them on one of these new oral anticoagulants and just send them home in some cases, right? Sometimes they don't have to get admitted if it's a pretty minor DVT or something like that. So again, that is changing. You'll probably see that change on your clinical rotations when you actually get out there, right? Our last section of cardio we're going to be talking about. So let's talk about CHF briefly here. What is CHF essentially? Your pump is basically not working too great, right? It's not very efficient. It's getting kind of weak. You're going to find ischemic heart disease is a big leading cause for a lot of these things here. Things like MI, chronic ischemia are going to be things that lead to CHF, right? We know that things like hypertension, cardiomyopathy also can lead to things like CHF as well in the long term. But certainly there's drug-induced causes. We'll talk about this in the chemo section coming up, but essentially there are certain drugs that can actually induce cardiomyopathies and lead to patients with CHF in some cases here. So there's a lot of different reasons why patients may develop CHF here. In terms of dysfunction, though, you can either have systolic or diastolic dysfunction, as we'll see here. The systolic dysfunction is typically a result of having decreased contractility, and a lot of that may be either due to things like loss of myocardial muscle mass, so maybe it's turned into scar tissue after an infarction. You have left ventricular hypertrophy because you've been overusing it, and you have a lot of afterload you're having to pump against over the long term, or if you develop this dilated cardiomyopathy, maybe due to drugs or alcohol or something like that. And usually you're going to see this will have a reduced ejection fraction, usually less than 45%. In terms of diastolic dysfunction, this is more of an issue of impaired relaxation. You can't really relax the ventricle well enough to actually fill as efficiently as it should, and this can be as a result of hypertrophy. As you think usually muscular hypertrophy is a good thing, right? You think muscles get bigger, you're able to lift more stuff. Not with the heart, really, right? You're going to find it gets thicker, it gets stiffer, it doesn't relax very well, and it could also be related to things like calcium not being able to be recycled very well, because we know that calcium causes muscular contractions. If you can't get rid of all that calcium in the cells, and they stay in somewhat of a contracted state. So there's some issues with that, and so you're going to find that you'll have a decreased cardiac output, even though the ejection fraction may look okay. Overall, you're not pumping as much blood because you can't relax that ventricle enough to really let it fill like it should. And so we're going to see that we have a compensatory response. If cardiac output goes down, then we're going to have things like increases and things like preload, right? If we're going to see that we're not pumping efficiently, then the body says, well, we must need more volume in the pump to make it work better, so we're going to hold on to more water and salt. What's a big thing that a lot of patients with CHF will present with? Peripheral edema, right? And that's a result of this increase in water and salt retention. You're going to see this increased preload, right? The volume heading back into the heart. You're also going to see a lot of vasoconstriction, which affects the afterload that the heart's going to have to pump against. And you see this sort of sick cycle where heart failure begets more heart failure in a lot of cases until basically the pump is just not working at all, essentially. You can see this here, how having things like decreased cardiac output is going to lead to decreased, say, for instance, tissue perfusion, which is going to lead to that neuroendocrine activation of the RAS system, the sympathetic nervous system, which is going to lead to increased afterload, which then, again, decreases cardiac output. So it becomes this sick cycle that we need to interrupt, and we already know a lot of the drugs are going to do that, and we've already talked about a lot of those, and so we'll talk about the drugs that CHF patients should be on in order to help make sure we decrease the mortality, hospitalizations, etc. So, and the common reason why you're going to see a lot of these patients is because they're coming in for decompensation, especially if you work in the ER, urgent care, something like that. And so it could be related to lack of compliance with medications or their diet. Could be due to maybe they develop an arrhythmia that causes them having an acute drop in their cardiac output. It could be a lot of different things here. And we'll talk about some of the reasons or some ways we can actually manage that. Now, talking about non-pharmacologic therapy, the best thing you do for these patients is to try to decrease their sodium and their fluid intake. That's overall is going to help with the edema. It's going to help for the heart to pump a little bit better because that preload is not going to be quite so high. And then obviously you want them to be able to be physically active. However, what's a big limiting issue there with CHF? It kind of limits their exercise capacity, right? Because again, the pump's not working all that well. They can't perfuse very well. They typically are not going to be able to exercise all that much. And so, again, it's going to be a slow process to kind of get them back on board. But every patient should be able to do at least something, and something's better than nothing, right? So, getting into the drugs. So we've already talked about almost every single drug here. So this is just going to be a review for the most part and looking at how we're using them specifically for CHF. So the diuretics, right? Remember, what's sort of like the best go-to diuretic for chronic hypertension management? Your thiazides, right? Indapamide, HCTZ, all those are going to be really good agents here. Thiazides are not really going to be super potent in terms of their ability to get rid of fluid off of a CHF patient who's got a lot of peripheral edema. It may be good for their hypertension, and so they may be on HCTZ or something like that in terms of their overall pharmacologic management. But in order to get rid of fluid, you got to use what? Loop diuretics. Which ones are loop diuretics? Furosemide, torsemide, bumetanide. What's the weird one? Ethacrynic acid, right? So again, most often though, furosemide is going to be the kind of go-to there. And so again, remember for CHF patients, it's not going to be something that they're going to be taking around the clock necessarily. Sometimes they may just use it as needed. How could you monitor a patient to know whether they're holding on to more fluid? Not necessarily urine output. What's something the patient could do at home that's easy? Weight, right? So they want to be checking daily weights on these patients. If they notice their weight's going up by couple pounds several days in a row, they're probably holding on to more fluid, and so that means that they need to maybe take their water pill, maybe take their loop diuretic in order to help get rid of some of the fluid there. Now, what are some issues you may run into with loop diuretics? What are some side effects? Increase or decrease potassium? Decrease potassium. Hypokalemia is a common thing. We're going to see that's going to be an issue looking at some of the other drugs we'll see there. Any other things? See hyperglycemia due to some of the sodium insulin effects you can see sort of as a secondary mechanism. Mention what else? Phototoxicity potentially, hyperuricemia. So there's certainly some side effects. We'll focus a lot on the electrolyte issues as we're going to see here. What other electrolytes do you lose a lot of with loops? Calcium, magnesium. Yeah, those are the big ones, right? And sodium, obviously, you're going to lose as well. But again, you may have these patients who are going to be using things like furosemide more on an as-needed basis. These loops don't have any sort of mortality benefits that we've been able to see, but it's good for symptomatic relief. So depending on their patient, may be on it all the time. Sometimes it may just be on it as needed. So again, these are not mandatory therapy, but certainly have the patient monitor their weight. If it's starting to go up, then yeah, they probably are going to need to use a loop diuretic to help get rid of that fluid. Now, ACE inhibitors. ACE inhibitors are going to be mandatory therapy for these patients. And why is that, do you think? It's part of that compensatory response we talked about is activation of that RAS system. And remember, what does the RAS system do to the left ventricle? It remodels it. Remember, after an MI or say due to chronic stress due to maybe high afterload, you're going to find that remodeling occurs. And so by having an ACE inhibitor on board, you interrupt that system, prevent the effects of angiotensin II from affecting the heart, and you keep it working better for longer. So we do see decreased mortality, we see decreased hospitalizations when they're on some sort of way to inhibit the angiotensin system, right? Now, it doesn't have to be an ACE inhibitor, it could be an ARB. Either one of these are going to be totally fine, though. But remember, if they have hypertension, ACE inhibitor might be a little bit better, but if they have side effects, then ARBs are going to be better for those patients there. Anyway, so this is going to be definitely mandatory therapy for these patients here. What other kinds of patients could benefit from an ACE inhibitor? Diabetic patients. Do you think CHF and diabetes are common comorbidities? All right, so again, you're seeing double benefits from these medications being on board here. So we're going to see better exercise tolerance. We're going to see decreased heart failure symptoms. All these things are going to be benefits of using ACE inhibitors for these patients here. Now, we talked about problems. Now, what do ACE inhibitors do to kidney function acutely? It can decrease it, right? So if you have patients that are really requiring that angiotensin II to clamp down on that efferent arteriole, that can be an issue, right? So this is something you may want to start low dose and gently titrate up. And that's going to be kind of the mantra here with a lot of these heart failure medications. Start low and go slow, because you could potentially tip them over into an exacerbation, decompensation coming into the hospital, right? So you don't want to do that. Now, what do ACE inhibitors do to potassium levels? It increases. Why does it increase it? Inhibits RAS, but more specifically, what does it inhibit the release of? Aldosterone, right? Because it interrupts aldosterone, so you're going to see potassium levels go up, which is good because that, in some cases, because that can offset maybe the hypokalemia that could be induced by the loop diuretics, right? However, if they have arrhythmias and maybe they have renal failure and their potassium's already high, then this could be a problem, right? So these are things you want to be able to monitor for, right? Now, other groups of drugs here you want the patients to be on are going to be a beta blocker. Now, remember what we said about beta blockers. What could they induce in a heart failure patient potentially? Because we said that patients with heart failure are going to have a kind of poor functioning left ventricle, contractility is going to be down, it's not pumping very effectively. What a beta blocker, what would that do to that? It would decrease it even more. So it seems kind of oxymoronic. You're like, why would I put a beta blocker on the heart failure patient? It's just going to worsen them. And in fact, if you were to say take a heart failure patient and put them on full blast beta blocker, yeah, you probably would decompensate them and send them into the hospital, right? However, what we can do though is that by starting again very low dose and gently titrating up, we found with these 3 beta blockers, specifically carvedilol, bisoprolol, and then specifically metoprolol succinate, remember that's the XL formulation, we do find decreased mortality. And that kind of makes sense because if you think about in the long term, if you're kind of decreasing the overactivity on the heart, because remember in that cycle we talked about, the sympathetic nervous system was also in play, decreasing beta activation, you're going to decrease stress in the heart, and overall you're going to see that it helps to extend life for these patients here. And again, because of that risk for decompensation, we typically start them off in the hospital. So we kind of maybe doing it after a decompensation, or maybe we're starting it on them, say for instance, after they had an MI, maybe before they develop heart failure symptoms, you would start them on a beta blocker. Is going to be good. Start them on low doses, and then sometimes over 6 to 8 weeks, you have to work on this titration to get them up to kind of full doses there. And all the while, you're saying, hey, monitor for signs of worsened heart failure. You know, things like decreased exercise tolerance, peripheral edema, all those things you're going to be monitoring for as signs of worsening heart failure. Now, the benefits here, we see that overall in the long term, it'll help to increase exercise tolerance. It'll help with these hemodynamic improvements, right? So if they have hypertension, this is going to help with that. And then what we've seen from the studies, though, is it has decreased hospitalizations, mortality, and the need for eventual cardiac transplant. So all really good things for these patients. So far, if you had to say what do patients need to be on when they have heart failure, we know the ACE inhibitors and beta blockers. What about loop diuretics? Do they have to be on that? Not necessarily, right? Do they have to be on a thiazide diuretic? Not necessarily, right? Their blood pressure is controlled with an ACE inhibitor and a beta blocker, then you don't have to add on a HCTZ or something like that at that point, okay? Again, think about what things are necessary and what things are going to be add-ons potentially. So again, they have anywhere between class 2 to 4 heart failure, they need to be on a beta blocker and an ACE inhibitor, irrespective of their symptoms. Now here's a new drug we haven't talked about before, I don't think. It's called Digoxin. Anyone know where you can find Digoxin? Or Digoxin-like compounds? Foxglove. Anyone know any other plants? What grows here? A lot, if you're like driving on, like say, on the interstate, it's a lot of the medians. It's these nice, pretty pink flowers and stuff. It's called oleander. You see, there's a lot of amateur botanists here. That's okay. But again, something else you can wow your friends with is actually the oleander that grows a lot. I always see, like when I'm driving on the 417 going home, I always see a ton of oleander there. It's actually toxic if, say, a kid or an animal were to get into it because it has digoxin-like compounds into it. But foxglove, lily of the valley, all sorts of things there. So anyway, so this is going to be sort of an old school drug. It's very old. We used to use it back in the day when we called heart failure dropsy back in the day, but it's been around for a while. We'll talk about how it works for CHF. So at the baseline, what digoxin does is it inhibits the sodium-potassium ATPase pump. Okay, what does sodium-potassium pump do for us? So remember, when you're looking at like nerve cells, when you're looking at cardiac cells, this is important because it helps to establish the resting membrane potential. Okay, remember, anyone watch those videos I posted in my physiology class? If you decide to watch those, you will see when we talk about the cardiac conduction cycle, and I'll mention it briefly coming up with the antiarrhythmics, you'll see that when you have that phase 4 of the depolarization, that's sort of the resting phase, right? That's going to be where you're getting back to the resting membrane potential of that cell, and that's important because if you're too high or too low on that, that can usually lead to dysrhythmias. Now, normally the sodium-potassium pumps sodium which direction? Out of the cell. And again, is that along or against the concentration gradient? It's against the concentration gradient, right? Because what's your normal serum sodium level? Let me know. Wild guess. So between 135 and 145 is a typical, that's milliequivalents per liter. That's a normal sodium level, right? What's a normal potassium level? 3.5 to 5. So there's a heck of a lot less potassium on the outside of the cells and a lot more sodium. So when you had the sodium potassium ATPase pump, is that a passive pump or an active pump? It's active because it uses ATP, it's right in the name. So it's pumping sodium against the concentration gradient. But where do we have a lot of potassium? Inside of our cells. And in fact, if we were to look at the potassium content inside the cells, it's probably between 135 and 145. So they're kind of inverse to one another between the outside and inside of the cells here. I always like the analogy of your cells are kind of like salt-wrapped bananas, right? Because there's a lot of sodium on the outside and a lot of potassium on the inside. That's just how I remember it. Anyway, so you'll find that sodium is being pumped out of the cell and the potassium being pumped into the cell against the concentration gradient. And that's what maintains our normal resting membrane potential, okay? So what digoxin does is it inhibits that pump altogether. So this is not working anymore, or is decreasing its activity here. So what does it do to intracellular sodium concentrations? Go up or down? They'll go up because this pump is not sending it outside of the cell anymore, right? So it's going to go up in these cases here. What that means is that there's this antiporter here that normally will exchange sodium for calcium. So now that there's more sodium inside of the cell, it's going to put this pump into overdrive because there's so much extra sodium that doesn't have a means to get out. It's going to start to use this pump here. So sodium will go out of the cell, calcium is going to come into the cell. And what does calcium do within the myocyte? Causes contraction. So by increasing the amount of intracellular calcium content, you increase contractility. Okay? So at a baseline, this is what we used digoxin for a good long time, is to increase the contractility of the heart, which we know in heart failure patients is diminished, right? That's the heart failure part of it, is they have a decreased contractility in a lot of cases there. So we use it as a positive inotropic agent, meaning it increases that contractility. That's sort of the older mechanism. Nowadays, we realize there's newer mechanisms that how this works. So for instance, it can do things like decreasing sympathetic activation and increasing parasympathetic activation, which can be useful for these patients here. It can resensitize your baroreceptors. What's a baroreceptor do? Detects pressure, right? And what happens to patients who are, say, chronically hypertensive? The threshold goes up and they kind of get used to a new normal, right? So again, if you came into this room every single day and it was always 81 degrees, that's just your kind of your new normal at that point, right? And so if it came in and it was like 78 the next day, you'd be, oh, it's kind of chilly in here, right? Same thing happens to the baroreceptors, to where you're going to see that they get kind of this new set point. And so by using digoxin, you can try to bring that set point back down. And that can be very beneficial for these patients as well. And it will also decrease renin-angiotensin activation. These are the new reasons why we're going to be using this for CHF in these patients here. So again, by increasing parasympathetic activity in the heart, what does that do to heart rate? Usually slows it down, right? You have more muscarinic activation in the heart, it's going to slow things down. That's going to allow for the heart to have better filling time and then with the positive contractility, allow for a better, more efficient sort of pump there. So overall, you're going to see that it works more efficiently. The cardiac output's going to go up in these patients. So this is why we like it for heart failure. And again, by decreasing renin-angiotensin system activity, similar to ACE inhibitors, we know that's beneficial. You see better perfusion of the tissues. All these things are pretty good for our patients here. Now, the issue with digoxin, though, is a very narrow therapeutic index drug, which means what? You have to do monitoring for it, right? You have to do blood level monitoring for digoxin. And if you note here, it does not take a whole lot for it to actually have its actions here. The target levels we'd be shooting for is between 0.5 and 1 nanogram per ml, right? Normally with drugs, we measure them in like micrograms per ml. This is nanograms, right? This isn't even another factor of 1,000 less. So it does not take a whole lot. Higher concentrations, though, actually can worsen heart failure because you're going to see that it can actually depress cardiac activity, as we'll see in just a little bit. So what the benefits you're going to see with this drug is that it will have improvement in symptoms, you're going to have better exercise tolerance, you're going to have increased quality of life. However, what they've not found is that it does not provide any survival benefits. So this is good for symptomatic relief, not necessarily good for helping your patients live longer. Okay, so if I was asking you which of these drugs are mandatory treatment in CHF, right now all you would be able to say is what? ACE inhibitors, maybe ARBs, and then those 3 beta blockers, which were carvedilol, bisoprolol, and metoprolol tartrate, succinate, right? The long-acting formulation, right? So anyway, digoxin is not mandatory in this case, is there? Now, what you're going to find is if patients are on optimal doses of their beta blockers and ACE inhibitors, they still remain symptomatic, and then this is where digoxin can come into play for these patients here. Or in some cases, we used to use digoxin, and still in some cases, we use it for control of AFib. This may be useful if a patient has AFib and heart failure. You can use digoxin for them as well. So that could be one case. Now, there's a lot of toxicity with digoxin, and this is something that you have to be really cognizant of when treating these patients because, again, this could be signs that they have way too much drug on board. It could lead to dysrhythmia, it could lead to decompensation. You have to be really careful with digoxin and its effects here. So one, GI effects are going to be pretty common when levels are too high. They have anorexia, nausea. Actually, I'll tell you a quick story here. So when I first got into pharmacy school, like the first year of pharmacy school, like you really don't learn a whole lot about actual drugs. Like it's mostly just like pathophys and a lot of microbiology and medicinal chemistry and all this kind of stuff. You don't really learn like a lot about the drugs, but like you're kind of like have a heightened sensitivity to drugs. So like when you hear people talking about them, you kind of perk up a little bit. I'll never forget as one time I was at the YMCA in Jacksonville, and I was just like, I don't know what I was doing. It's probably like maybe I was on a treadmill going along, and at the YMCA, you know, there are certain older gentlemen that like to hang out there quite a bit, right? And so you have these old guys that just hang out all day long and they just sit there shooting the breeze, right? This one guy was like, yeah, I just started this new heart medication, but it's weird. I got all these like, I don't know, there's like bright lights that are like just, I don't know, they're really bothering me, and they have these like weird like kind of yellow halos around them, and I was like, that's really strange. Like, I wonder what that is. I did not learn until later that the guy was probably experiencing digoxin toxicity, and so this is very typical what that patient, I hope he did okay, I don't know. He's pretty old anyway, might have died, who could say. But I don't know. These guys come and go all the time. But point being is that he was explaining very typical sort of side effects of having too much digoxin on board. So he probably needed to have a level done, and probably had his dose reduced here. So you can see things like photophobia. You get this like sort of yellow-green halos around bright lights. It's like fluorescent lights will have that. Anyone know what that's called? Like sort of yellowing of the vision? Xanthopsia, right? So that's the medical term for that. Again, something you can wow your friends, preceptors with. Oh yeah, it's xanthopsia the patient's experiencing. But that's essentially what you're going to be seeing with that. It's very prototypical of digoxin. Not many other drugs are going to do that. You can also see some central symptoms as well, things like dizziness and confusion. Abnormal dreams is another thing you'll see when levels are too high, so you do want to be careful and watch out for that. Now, the biggest and the most worrying thing, so you know, patient's not going to die from seeing yellow halos, right? The patient will die though from the arrhythmias they can develop that come along with having that high of a level. So you can see things like decrease in the QT interval, increase in PR interval. You see these kind of weird changes in terms of the EKG. The most common thing you're going to run into though is sinus bradycardia, and again, that can be part of the mechanism. Could help with the increasing the efficiency of a pump to a point. If you decrease that too much, then we can obviously see how that can cause a decompensation for these patients here. And so what you can find is it can cause severe bradycardia, it can cause AV block. Also, what do you think is going to happen to potassium levels with digoxin? Why do you think it increase? Because I'm inhibiting that pump, I'm not sending as much potassium into the cell anymore, so potassium levels are going to go up. Well, having too high potassium levels can put me at risk for arrhythmia, right? So if they're on an ACE inhibitor, if they're on, say for instance, digoxin, and maybe they're taking a potassium supplement, all of that can really lead to some big issues in terms of causing arrhythmias, as we'll see in just a moment. So you have to be really careful with that in terms of these patients here. So again, if they already are hyperkalemic, digoxin is not a good drug for them. They have renal dysfunction and they can't clear digoxin. This is not a good drug for them. You have to be really careful here because there's a lot of contraindications. Now, what could I do to reverse the effects of digoxin toxicity? Well, I can give them something called digoxin immune fab. This is actually an antibody that's derived from ovine sources. You know what ovine means? What kind of animal it is? Porcine would be what? Be pig, right? Bovine would be cow. Ovine, sheep. Yeah, it actually comes from sheep sources. So sheep have been, again, something else you can impress your friends with. I know I put it on this slide. Goes to show you, if you read my slides, you usually have all my answers right ahead of me. But point being is you actually have sheep will hyperimmunize against the digoxin. Basically, they get small doses of digoxin given to them to where they'll develop antibodies against it. We'll then isolate that out, and then we'll actually give that to the patients to neutralize that digoxin. What's actually interesting, though, is that normally you'd be worried about if you're injecting animal protein into a patient, what would you think it could be a risk? Anaphylaxis, right? Because it's a foreign protein. Even though your patients may be bashful, they typically do not react well to sheep proteins. What we do, though, is actually if you look at the structure of an antibody, right? So say you have your FAB portion and then your FC portion, it's a fairly large molecule that you can have a reaction to. What we'll do is we actually chop it up, and so we'll actually cleave this part of the FC portion off of it. So this is the active form of the drug, and that actually is much less likely to have reactions to that. So it's really cool because you see very little anaphylactic reactions, but it's really good. It'll basically, you'd have a patient who's having an acute arrhythmia due to digoxin. You give this drug, it'll bind it up immediately, and the patient goes back into normal sinus. So it's really interesting when you actually see it work. Okay, so actually let's go ahead and do a 10-minute break now. We'll come back and then continue with our heart failure meds. Just a couple things on the prescription assignments that I was noticing. One, make sure you use just US names. If you did so, I've made comments about that. Note that I don't count off on everything that is like style stuff. Like sometimes I'll just make comments, hey, you may want to do this next time, right? Usually it's going to be things like the volumes are off, or if you're missing something like a route or your signature or something like that, then I'll count off for that kind of stuff. Typically though, you want to make sure that your volumes make sense for what your actual instructions are, right? So for instance, if you're writing for 10 days worth of medication, the volume, if they're taking 6 mLs a day, it should be 60 mLs on there, right? Don't write for the entire bottle size because that's going to be way too much, and the insurance wouldn't pay for it. The pharmacist wouldn't really dispense that much, right? We would be able to split those bottles in those cases there. That's for oral liquid medications. Typically for things like creams, like topical creams, like those only come in the tube. We don't really divvy those out, so that's fine to put the total size of the product there. Otic drops, ophthalmic drops, you can put the total bottle size. Those are totally fine. It's the oral liquids, though, you want to be more specific about your dose. So for instance, if I was writing for something like hydrocodone acetaminophen, a controlled substance, and the patient only needed 60 mLs to fulfill their prescription, but I wrote for 237 mLs, no one would ever fill that, right? Because it's way too much. They don't need that. So that's one thing that just kind of keep in mind as you're going forward. Okay? Yes, ma'am.
So how about for that diurese, which is a maintenance medication for the
Yeah, so how much would you write for that, do you think?
I mean, like, it's supposed to be maintenance. Can we not do like the lowest bottle available? I mean, how could they just actually
Remember, so in the pharmacy, we'll fulfill whatever size is needed for that patient there. So, right, if the patient needs for an entire month, they need 200 mLs, then just put 200 mLs on there and we'll fill that bottle size to that volume, right? Because some bottles will come in a pint size, some of them will come in, 237, 470, there's different sizes that are out there. You don't have to concern yourself with that. Just write the volume that is necessary for their specific prescription for that month or whatever period they're taking that drug for.
Yeah, I mean, if it's continuous, can we give more than a month?
No, because the insurance won't pay for that, right? So that's the thing you run into is the insurance does, yeah. Because when you're writing for those refills, it's saying, hey, they're going to come in another month and they'll get that same volume again. You don't want to write for more than what they actually need for, right?
So when you write, you said like you can get like 30-day supply, and you can give up like 5 refills per year. So is that a total of 5 months or 6 months?
So I think for non-controlled substances, how long are those scripts good for? A whole year, right? So you can write for 11 refills, right?
Plus the 30 days.
Plus, so you'd say like 1 plus 11, you could do that. So you get the initial fill plus 11 refills on there, right? Or you could write for, some people will do like a 90-day supply. So for some of those chronic meds like the lisinopril HCTZ, right? If you're writing for that, and again, a lot of people I saw were separating them out. You can use the combo drug. That's totally fine. That's kind of what the intent was for that one, to see that, hey, there's actually a combo drug. Let's use that for compliance sake. But in that case there, you could write for a 90-day supply, the insurance, and say, so 90-day supply plus 3 refills to get the entire year's worth. Now, even if the insurance company didn't want to pay for that, they said, I only want to pay for 1 month at a time, us in the pharmacy, we'd be able to work it out to where we say, okay, well, those just get 11 refills at that point, right? So that way the total amount of drug they're getting fulfills what you wrote for. Everything kind of works out in terms of the math there. So again, those are little process things that you guys are going to figure out as you, this is kind of the point of the prescriptions, is so I can kind of inform you of that kind of stuff. Hey, this is normal, this is not normal. So that way when you get on rotations, you're not writing for crazy stuff that your preceptor's like, what are you doing? Like, you've never written a prescription before? You can say, nope, I definitely have. I can't blame this on Dr. Wood if I screw something up, right? I'm just kidding. No. You still can. I won't be there to defend myself, so that's fine. Anyway, so let's keep going. So any questions from the first half? So continuing on with our CHF talk. So next off, we have our aldosterone antagonist, right? So we have 2 drugs that fit into this category. We've talked about previously. We have spironolactone and then milrinone. These are going to be good for patients that have more progressive CHF, so grade 3 or 4 heart failure. These can be useful. They actually do provide some mortality benefit, but there are some caveats. You don't want to use these in patients that either already have hyperkalemia, so their K is above 5, because what will these drugs do to K? We go up, right? Do you guys want to hear a joke about potassium? Okay. Anyway, so that would be one reason you would not want to do that. And then if the serum creatinine is above 2.5, why do you think that would be a contraindication? Because patients with renal failure oftentimes have what? Hyperkalemia, or they're at risk for hyperkalemia. Why is there got a long tail on it? See, some people are just now getting to bed. It's okay. Anyway, so be careful with that. Just be aware that they have hyperkalemia or they have high serum creatinine indicative of renal dysfunction. You don't want to give these drugs to them, right? It's going to be contraindicated for these purposes here. Remember, spironolactone has some androgenic, meaning testosterone, sort of partial agonist effect. So you will see things like gynecomastia in male patients. You can see things like hair growth or hirsutism in female patients. It just depends on who you're giving this to. Pleuronidone gets around that by causing less of that in a lot of cases there. Okay, and this really helps out with further interrupting that renin-angiotensin-aldosterone system to help prevent that remodeling of the left ventricle. So here's some other agents we may use occasionally. So say, for instance, your patient does come in with a CHF exacerbation and you want to do something to sort of acutely increase cardiac output. We have a couple of drugs that can do that. And so we have milrinone and anamrinone. These are actually going to be cyclic AMP phosphodiesterase inhibitors. Now, where have we seen that term phosphodiesterase inhibitors before? Mentioning them with the nitrates. Remember, you don't want to use the nitrates with what kind of drugs? Erectile dysfunction meds, yeah. So remember, there's different types of phosphodiesterase. Ones that are used for erectile dysfunction and pulmonary hypertension is PDE5. This is specifically PDE3. So these are going to have different actions of what you would see with something like that. So basically what it's going to do is it will cause, one, it'll increase cyclic AMP levels within the heart to actually directly stimulate contractility, which may be acutely decreased in these patients who are decompensating. And then another thing it's actually going to do is it will help to decrease afterload by causing some vasodilatation. So if a patient comes in, they're hypertensive, and they have decreased cardiac output, and they're in this exacerbation, their lungs sound all junky because the fluid's building back up in there, you can give these drugs IV to sort of kind of kickstart the heart a little bit to increase cardiac output. The vessels dilate, so afterload decreases, and overall you're going to find that it helps with the efficiency of the heart. And so these are used acutely IV to get kind of patients back to a stable point, and then you'll kind of wean them off of that and then get them back on their chronic meds there. Just be aware these drugs can cause things like ventricular arrhythmias, cause things like thrombocytopenia, so there are some risks with them. And they actually found that we don't like to use these long term because they actually increase mortality. But in the short term, if you need it very briefly, these can be good drugs to use for them. Two other drugs you may see being used in this situation as well. One's called dobutamine. This is specifically a beta-1 agonist. So by giving a beta-1 agonist, what would that do to cardiac output? Increase it, right? So contractility will go up. What does heart rate do? It would increase as well, right? Because it's directly stimulating beta-1 receptors there. So again, if a patient came in with a beta blocker already on board, this may decrease the efficacy of the drug, but by giving higher doses, you can get around that. But these can be used for short-term utilization here. Also, if you are familiar with patients who are getting like cardiac stress tests being done, sometimes dobutamine will be used as a chemical stressor on the heart to look for EKG changes and things like that. So if you had a patient who maybe couldn't tolerate walking on a treadmill or something, you could use something like dobutamine to stress out the heart to try to see if there's any kind of ischemic changes that occur in those cases there. And then another one called dopamine. This is actually going to be working in addition to stimulating beta-1 receptors. It also stimulates alpha receptors as well. And so dopamine basically will work both if you have issues with cardiac output and if you're hypotensive. This is a good drug for that because it actually will help to stimulate both the vessels to constrict and will increase cardiac output as well. Now, normally dopamine you think about as what? Doing what? Used for things in the brain like movement and your reward pathway. However, this dopamine, when given via IV, can't get across the blood-brain barrier. So it's not like you all of a sudden get like super euphoria from giving dopamine IV. Basically, you just get depressor effects, and that's kind of it. So that's it for CHF. So know what medications a patient should be on. Know which patients they should be wary of, and things to avoid potentially. Notice, were there any calcium channel blockers that were used in heart failure? No, right? Do I want to use something like a non-DHP for someone with heart failure? No, it's just going to depress the heart further. I don't want to do that. What about something like a DHP, like amlodipine? Would that be okay? Yeah, it doesn't act on the heart. Potentially, if they still need some additional help with the blood pressure, then you could do something like that. That might be reasonable in those cases. So just something to consider. Getting into our antiarrhythmics. Okay, so now we're talking about antiarrhythmics. We'll talk about different effects on the heart. Again, I posted up a video talking about cardiac conduction that you may want to review that can kind of help out with some of this. Note here that with any antiarrhythmic, guess what it can cause? An arrhythmia, right? So be very careful with these drugs because they can be quite dangerous when used inappropriately. Now, normally cardiac muscle you're going to find is striated muscle, kind of like our normal skeletal muscle here, but it's interesting because it actually has what we call these intercalated discs that allow for transmission of ions to go through the cells very easily. And so this allows for a nice concentrated sort of a controlled sort of conduction cycle. We call this a functional syncytium because if all the cells in the heart just all contracted at once, would anything really happen? No, but it needs to squeeze appropriately. It needs to go down from the bottom of the ventricle, squeeze up in order to make sure that we get that blood coming out appropriately. Otherwise, we develop arrhythmias, right? And again, we're going to find two different types of tissue we'll talk about. We'll talk about nodal tissue, meaning things like the SA and the AV node. And to lesser degrees, you can talk about like the bundle of His and the Purkinje fibers and things like that. They'll be transmitting these action potentials through the heart in order to cause the actual contraction to occur, right? So normally what you're going to find is that the SA node will have sort of the highest sort of intrinsic rate, that's sort of setting the rate for the heart. And then you'll find that, you know, even if you ablated the SA node, you still have things like the AV node that will be a little bit slower, but can still set the rate here. And you see it will get slower and slower as you get down into further cells. Things like the bundle branches, you know, they're going to be even slower, but they still have some intrinsic rate to them themselves. But anyway, normally the SA node was going to be kind of taking control in terms of heart rate. Have you guys covered any EKG stuff yet?
Yeah.
Because you're like expert EKG readers? Probably better than me, right? I'll get a lot of training on that. But let's look at what happens here. So normally if you're looking at fast response cells, when I say that, I'm talking about like just typical atrial cells or ventricular cells. These are ones that don't have any automaticity to it, right? They don't have any intrinsic sort of rate in and of themselves. You're going to see that it gets divvied up into different phases. And you guys covered these phases before? Talk about them here, right? And again, you can review that video, also go into more detail on that, so I would recommend checking that out if you need a refresher. Normally what you're going to find is that as an action potential comes along, say coming from the SA, the AV node, it then triggers off these cells to have its own action potential, and that will happen, and again, notice here it's normally at a nice resting membrane potential. Once that action potential comes along, it opens up sodium channels, okay? You get a big spike in electric potential as sodium rushes into the cell. Now, is this along or against a concentration gradient? Along the gradient, right? Because the cells open up, sodium flows in, right? So that will cause the initial depolarization of that cell. You'll then find you'll have a little bit of, in phase one, this kind of outward potassium. So you see that little notch there? That's related to potassium going out of the cell and then chloride coming in, right? So chloride would do what to the electric potential if it comes into the cell? Because it's negative, right? So it would drop it back down. So positives flowing out, negatives coming in would cause it to go back down. So you see that little notch there. But then you notice kind of this plateau that occurs. This is phase two. This is mainly due to inward calcium currents, okay? Now, calcium is also going to do what to these muscle cells? It'll trigger off the sarcoplasmic reticulum to release calcium, and that leads to contraction, right? So again, this is all in service of getting calcium into the cell so that it will cause the actual contraction to occur. Now, do we want the cell to remain at this high electric potential all the time? No, it needs to reset at some point, and so you're going to find that now you have outward potassium coming out of the cell. It's going to be causing the repolarization of the cell, and then eventually get down to phase four, the resting phase, where the sodium-potassium pump is maintaining that, okay? So sodium going out, potassium coming in, it maintains that resting membrane potential, okay? And again, you can kind of see how this would occur. Say this is a ventricular cell. Normally you see sodium rushing in during phase zero. There's that little notch here. Sodium channels then close at the end of phase zero. You start to see potassium starting to come out of the cell a little bit. Cause that little bit of a notch there. Those then close. And then you find the calcium that will then open up. So calcium channels will allow calcium to flow into the cell. That triggers that release of sarcoplasmic reticular calcium to cause the contraction to occur. And then finally, we're going to see the potassium channels then open up. These are potassium efflux pumps, causes the repolarization to occur, and then you're back at resting membrane potential. Okay? Make sense so far? Clear as mud?
So for phase one and phase three, you have outward potassium, but why in only phase one are you also getting chloride?
You getting what as well?
Is it chloride or chloride?
A chloride.
Chloride. Why are you getting chloride in as well as potassium?
That's just how it works.
So, but for phase three, it's just not happening.
Yeah, so if you're looking at what the primary movers and shakers are, so there might be a little bit of chloride movement around, but it's not clinically relevant to us, right? We really care about the potassium efflux there.
So 3 is the repolarization?
That's repolarization. So this is the initial depolarization, then you have the contraction phase, and then you have the repolarization.
Okay, so the initial is going to be with the repolarization out.
Yes. Don't get hung up on the chloride though. Don't worry about that one. The potassium is the big stuff I care about. The calcium, sodium, potassium, all that stuff's good. Now, going into that, we talk about refractory periods. Now, what's a refractory period? It's a period of time where the cell cannot have another action potential being triggered off. This is what we call an absolute refractory period and a relative refractory period. Okay, absolute means what? Nothing can trigger off another action potential. The cell is just at a point where it is early enough on, so say like during this early repolarization, nothing's going to trigger off another action potential. Okay. In the relative refractory period, as it starts to come back down and gets more close to the resting membrane potential, now strong signals can come along and then trigger off another action potential, right? So say for instance you have an ectopic foci or a piece of cardiac tissue that is sending off its own signals inappropriately. That can then come across and potentially re-trigger an action potential to occur in this cell here too early, and what could that lead to? That then can cause arrhythmia, right? Because again, if things are not triggering off in the appropriate order, this is when you develop arrhythmia. And again, if you have VTAC or VFib, where the cells are just sitting there quivering, the muscle's not contracting in that nice functional syncytium, nice concerted manner, this is where you develop arrhythmia. You have no cardiac output and the patient dies, right? This is important. Now, going into the slow response cells, these are going to be the cardiac pacemaker cells. These are SA-AV node primarily. Notice here there's a little bit of a difference in terms of where the ions are going. So during phase 0, normally you're going to have sort of this initial opening of the channels. This is where calcium is going to flow in. Now notice, what do you notice about this line here? Because with the fast response cells, you notice the resting membrane potentials, it's a flat line. What about this? This how it's kind of curved? It's kind of sloped up. There's leaky sodium channels that are in there, right? So determining how much sodium's coming in will determine how fast that cell is going to reach that critical threshold to have an action potential. So if I allow a lot of sodium to leak in, it'll hit this much sooner, then the heart rate should be faster. If I slow this down, you're going to find if I have less sodium coming in these cells, then it's going to take longer to get to phase 0. The heart rate's going to go down, okay? So sodium conductance here is really important for the nodal tissue. When you have phase 0, once you get to that critical threshold, calcium is what's going to flow in here, right? Remember, what drugs can affect calcium influx into the heart? Calcium channel blockers, non-DHPs, right? What did non-DHPs do to the heart rate? Slows it down, right? This makes sense because it's affecting these L-type calcium channels, right? So you're preventing calcium from flowing in when you use something like a non-DHP. But normally what would happen, you have inward calcium current, but when you have phase 2 into 3, you're going to find that it's mostly potassium being effluxed out that allows for that repolarization to occur. Then you're going to find that it's the sodium-potassium ATPase pump along with those leaky sodium channels that will then allow for the recycling and getting back to phase 0 eventually. So again, how fast this is occurring is going to set the rate for the heart, and how fast all the other cells are then going to be eventually triggered off. Okay, so again, just kind of looking at it, you can see calcium flowing in here. You can also notice that potassium is going to be effluxing out. It's causing the repolarization, and then eventually you're going to get back to the sodium-potassium pump, kind of maintaining things along with those leaky sodium channels, along with that slow inward flux. Okay, so ideally, when you're dealing with an antiarrhythmic drug, you'd like to be able to deal with the underlying cause. So, for instance, if the patient is having, say, an arrhythmia due to ischemic tissue, what can you do? Well, I can reestablish blood flow. Maybe I go in with the PCI, go into the cath lab, and open the vessel back up, right? If it's due to hypoxia, give the patient some oxygen, right? Fix the underlying cause in a lot of these cases here. If it's electrolytes, get rid of the electrolytes, or maybe give more depending on what the issue is. And then what you're going to find is that when you're giving these antiarrhythmic drugs, you want to make sure you know what your goals are. Am I looking to maybe just, say, control the heart rate, even though I may leave, say, for instance, the atria still in a dysrhythmia? I just want to control the actual heart rate. Or do I want to actually get rid of the dysrhythmia altogether and go back to normal sinus rhythm? You can have different goals depending on the situation there. And depending on things like ischemia, depending on things like hypoxia and things like that, you can find that these tissues will change over time to where these arrhythmias may also require different therapy depending on the situation there. So anyway, so again, looking at our classification for antiarrhythmic drugs is going to be based on their mechanism of action. So class 1 is going to include sodium channel blockers. We're going to find that class 2 is going to be our beta blockers. Class 3 are going to be potassium channel blockers. And then class 4 are our calcium channel blockers. This is primarily going to be the non-DHPs, okay? So diltiazem or verapamil, the only category 4 dysrhythmias, class 4 dysrhythmia, antidysrhythmics. The DHPs do not get included in this, okay? So just make that distinction. And so then further, class 1 is going to get broken down into class 1A, 1B, and 1C. And so basically the differentiation there is what type of channels are going to have more affinity to, and we'll talk about those different states for that sodium channel in just a little bit. We'll talk about a few miscellaneous ones towards the end here as well, as we'll see. Now, looking at the type of arrhythmias that you can treat with these different drugs here, I mainly want to point out that if the sodium channels are being affected, if the potassium channels are being affected, that can treat both atrial and ventricular arrhythmias, okay? It's going to be able to work on both types of tissues there, depending on where the arrhythmia is developing, okay? Class 2 and 4, which are beta blockers and calcium channel blockers, those are mainly going to be used to treat atrial arrhythmias. And why do you think that is? Because what do they primarily have effects on? That nodal tissue, right? Beta blockers do what to heart rate? Slow it down, right? Non-DHPs do what to heart rate? Slow it down, right? So this makes sense you would use it for an atrial arrhythmia, right? And when you're thinking about the relative importance of the atria versus the ventricles, if the atria is sitting there just kind of quivering away, does that really affect the efficiency of the heart all that much? Not really, right? Because again, what's the main thing that helps fill the ventricles during diastole? Huh? It's gravity, right? The atria really don't do a whole lot. They kind of contribute a little bit towards the end there, but I can have the atria not really doing much, and I can still have a pretty efficient pump. If the ventricles go, guess what? Patient's dead, right? That doesn't work. It's not compatible with life. So that's why in these cases here, you can have someone who is in AFib, but if I'm slowing down that conduction to make sure that that rate maybe of 200 in the atria don't make it down into the ventricles, so that way they're still at a pretty normal rate, then the patient can still pump efficiently, they're fine, okay? So just note 2 and 4 are going to be mainly for atrial arrhythmias or supraventricular arrhythmias, right? So above the ventricles. Class 1 and 3 can be both atrial and ventricular. We'll get more details on that in just a few moments here. And again, when we're talking about sodium channels, just know that they have different states, right? So there's like what we call the resting state, the activated state where they're actually open, and then there's what we call an inactivated state. And then part of that's during that refractory period, okay, before it resets itself to the closed state. Main point being is that the different drugs can have affinities for different forms of that receptor there, which can have different effects, as we'll see on the EKG in just a moment. So looking at the sodium channel blockers, the first one we get into is a class 1A antiarrhythmics. Basically what they're going to do is by slowing sodium influx, and remember that's going to be primarily affecting phase 0 of depolarization, right? The phase 0 for those fast response cells is mainly sodium influx. So by slowing that down, what do you think this does potentially to, say for instance, let's say you're looking at the EKG, right? Let's say you're looking at the QRS interval. What does QRS tell you? Ventricular depolarization, right? What do you think would do to the QRS? Make it longer, right? Because you're slowing down that sodium influx, right? So you see your QRS interval would say go up. The PR interval, which is telling you what? From atrial to the ventricular depolarization, that's getting longer as well because you're slowing down that sodium influx there. All that's going to be related to blocking those sodium channels, right? So it affects both atrial and ventricular actual depolarizations and conduction there. And so you're going to find that when they bind onto there, and again, don't get so hung up on the channel affinity or the dissociation. I just want you to know where these different drugs fall into the categorizations because that will come up, say if you're on a cardiology rotation or something like that. But mainly they're going to be working on the sodium channels that block that, and they will slow down that depolarization phase. A couple drugs that fit into this category. Class 1A antiarrhythmics, you can remember PDQ. You know what that stands for? Yeah, people say chicken now, and I was like, what the heck? And then I was driving home one day, and I saw the PDQ, the chicken place. And you know what that stands for? People dedicated to quality, I think, or something like that. I always knew pretty darn quick, which, again, if you had an atrial or ventricular arrhythmia, you want to treat that pretty darn quick, so that's how I think about it. Again, it's probably showing my age more than anything else. It's like when I ask about what a CPK is, and somebody says California Pizza Kitchen. That was creatinine phosphokinase, but good try. Anywho, so PDQ are going to be the 3 drugs that fit into the 1A category here. So we're going to have quinidine, we're going to have disopyramide, and procainamide. We're going to see here in just a few moments. So quinidine, actually interesting, this is actually based off of, it comes from a tree actually, and so if you're ever familiar with the product called quinine, anyone ever heard of that before? Actually has some anti-malarial sort of capabilities here. But actually, if you ever, and you guys would never do this because you're fine upstanding individuals, but if you ever perhaps had a gin and tonic, you had tonic water, and you ever seen it under a black light? It actually glows. I'm teaching you something actually that can impress your friends potentially. So tonic water actually has quinine in it, and it actually will react to black light. So if you're ever really if someone is out at the club and there's black lights that are there, it will actually glow under that light, and that's the quinine that's actually in it. Quinine is actually related to quinidine. Quinidine is an isomer of quinine, right? It's one of the enantiomers thereof. And so basically what you're going to find is that, again, it works on the sodium channel. It's going to slow down conduction there. And overall, it's going to increase that threshold for excitability. So it's more difficult to have those action potentials, which means it kind of extends that refractory period. Okay, that's the big thing it's doing, is extending the refractory period, which makes it more difficult for those reentrant arrhythmias to then trigger off into their action potential. So you can arrest that arrhythmia altogether because you're making the refractory period longer. Okay. Other things this is going to do is it can also have some anticholinergic properties that can also do things like speed up the heart rate, so you have to be careful with that, and then actually can work to block alpha receptors. What would that do for us? Cause vasodilation and hypotension, right? So you have to be careful. Patient has low blood pressure, this might not be a great option for them. Now, where do we use this, right? We can do things like either maintaining say normal rhythm with a patient with AFib or aflutter, or if we want to control ventricular tachycardia. There's something we'll talk about. There's an issue of rate control versus rhythm control. Rhythm control are going to be things that keep the heart in normal sinus rhythm. This would be an example of rhythm control, right? It helps to keep the patient from going back into AFib, helps to control those ventricular arrhythmias there. And so this is where we're going to see this being used. In some cases, you can actually have what we call chemical cardioversion, right? So normally, how do you cardiovert the heart from an arrhythmia back into a normal sinus? You can use electricity, right? There's chemical means we can do this as well, and so this could be one limited example of how you could use a drug to convert someone back into normal sinus. That's one example there. Be careful, because this is actually a CYP2D6 inhibitor, so it could affect drugs like morphine. It could actually make them last a lot longer. You can see more side effects from that. Something that is pretty typical of quinidine, so this is one thing you want to know, is that certainly you can see hypotension, like we mentioned with the alpha blocking effects. You can see things like certain things like nausea, vomiting, diarrhea. Some of that can be related to some anticholinergic properties. The biggest thing you're going to see, though, is, or the most classic thing, is what we call synchonism. And synchonism actually has to do with the cinchona tree that this actually comes from. But basically, it can cause tinnitus, dizziness, and blurred vision. So if you had a patient who's taking quinidine and they develop this, that would be indicative of having too much on board, causing toxicity there, right? Now keep in mind, when I'm prolonging the action potential for those hearts there, for the cardiac action potential, what do you think that does to my QT interval overall? It's going to prolong that as well, and everyone knows that prolonged QT can lead you to develop torsades, right? And what is torsades? It means that twisting of the points, right? It kind of goes and gets bigger and goes back down, right? Basically, it's a very kind of typical ventricular arrhythmia you see as a result of QT prolongation. So this is going to be a risk with that, because overall, it's extending the action potential. QT is going to go along with that, right? So that kind of goes into that quinidine sudden death. Basically, the patient went into a ventricular arrhythmia caused by the drug, and it can be very difficult. Once that drug's on board, it's hard to get rid of to actually reverse the arrhythmias. Next up, we have a drug called procainamide. This is actually a fairly short duration of action here. This is more used like from an IV sort of standpoint, say in the hospital, in order to treat some arrhythmias. This is important to note, and we've talked about the drug hydralazine before, correct? Remember, what was the big kind of unique thing with hydralazine? Remember the lupus-like rash? Who was likely to get that? White girls, yes, were more likely. White females, yes, were more likely. Who else? Slow acetylators, right? Good. So that's the point I wanted to make there. So slow acetylators are more likely in order to develop that. So this is another drug. This is actually more common with procainamide than it is with hydralazine. It's just fewer patients usually get put on procainamide. But if you have a slow acetylator, they can get the same kind of lupus-like syndrome you would see with hydralazine. So this is the second drug we've seen kind of does that same thing there. So that'd be one thing to note with that. Again, you can see that lupus-like syndrome, about a quarter to half patients can develop this to some degree, and again, it's going to be more likely in slow acetylators there. And again, prolonged QT, torsades is going to be another risk with these drugs, just like we saw it with quinidine. And then this last one's going to be disopyramide. It's very similar effects to quinidine here. You're going to find it is even stronger in terms of anticholinergic activities. And again, you can see it's used either for ventricular or supraventricular arrhythmias, right? So no kind of unique side effects with disopyramide. Okay. Just be careful due to the decreased contractility. We know if they have heart failure, which again, sometimes that arrhythmia could have led to the heart failure or vice versa. Again, this would be a drug you want to be careful with because the decreased contractility could decompensate them. So those are the 3 1A antiarrhythmics. Remember PDQ. And then getting into the 1B antiarrhythmics, there's actually only one drug we're going to talk about here. This is actually interesting because this one has a very unique sort of use case here. It actually has a higher affinity for ischemic tissue than it would for other types of healthy non-ischemic tissue. So what kind of patient might that benefit? Actually, during an MI sometimes, because again, if you're having an MI, sometimes they can develop ventricular arrhythmias due to that ischemic tissue, right? And so this is actually a case here where lidocaine may be a really good option for those patients to help sort of arrest that arrhythmia. And so lidocaine is going to be the main drug we're talking about there. Now, lidocaine you normally think about as what? The local anesthetic. How does it work as a local anesthetic? We mentioned this before, I think, in the ophthalmology section. Blocks sodium channels, which does what to your ability to generate action potentials in the nerves? Decreases it, right? So it makes sense. I could apply this locally. You have things like Let gel. You ever heard of Let gel before? Applied to like a wound. It's lidocaine, epinephrine, and tetracaine. So you have 2 local anesthetics in there that will help to decrease sensation because you have less action potentials occurring. The same thing's happening here, it's just working on the heart, right? So this would be an IV infusion you give the patient to slow down their heart rate, and again, hopefully prolong that refractory period to prevent that arrhythmia, or treat that arrhythmia as the case may be. And so acute MI is a good use case because it has all that ischemic tissue you're working with. Now again, this one would be given IV only. This would not be something you want to use orally because there's no good bioavailability here. You're going to find that some of the things you want to be careful of is if a patient has, let's say, renal or hepatic dysfunction, they can significantly have a decreased clearance of the drug. So you really got to drop your dose on this and be really careful with that. Some of the things you would want to note if you have a patient who's developing anesthetic toxicity is usually they'll either start to develop some nystagmus, so some abnormal eye movements. They'll also complain about some like metallic taste in their mouth. That can be pretty indicative of anesthetic toxicity with that. So you want to be really careful because if I start blocking all those sodium channels, not only could I have dysrhythmia on the heart, but what do you think it does to the brain potentially? And cause seizures, right? Because if I'm disrupting normal neuronal conduction, I can actually see seizures that can develop from that. So that's why you want to be careful with lidocaine. And then we have 2 drugs in our 1C category. This is going to include flecainide and propafenone. These essentially are going to be working, again, to slow down phase 0, slow down conduction, and prolong that refractory period. So if you ever hear about patients who are on something called pill in a pocket, you ever heard of that term before? This is basically for some patients who are pretty stable, who maybe normally can stay in normal sinus rhythm for most of the time, but every once in a while they'll go back into AFib or aflutter. They can have basically this medication they'll have on an as-needed basis. They'll go ahead and just take, and that will then put them hopefully back into normal sinus in those cases. So not done too frequently, and in fact, for some patients we've seen increased mortality. So these drugs are not used quite as often anymore, but you still may see it occasionally. We have 2 flecainide and propafenone. Again, you're going to see this is going to prolong PR, QRS, QT, and everything gets prolonged because you're blocking the sodium channels and again prolong that refractory period there. And again, you can either use this for, say, patients who are developing life-threatening arrhythmias, either ventricular or supraventricular. And again, you could do that in patients as well on the outpatient basis to help kind of acutely treat those arrhythmias. In terms of toxicity, you do want to be careful here because you can have patients develop bronchospasm, so they have asthma. That could be a relative contraindication. And we do see increased mortality in patients with MI, so this would be one thing you probably want to avoid for them. And then propafenone is going to be the other one in this category here. This actually has some beta blocking activity as well, which can actually slow down the heart rate, which can also help with some of those supraventricular arrhythmias, so it can be beneficial. But do be aware of some blood dyscrasias like agranulocytosis. That could be a rare side effect of the drugs like propafenone. Okay, so then getting into our class 2 antiarrhythmics, these are just going to be beta blocking drugs, right? So you guys know all examples of those, right? Some beta blockers. Metoprolol, carvedilol, propranolol. Any of these would be good class 2 antiarrhythmics, right? Because they're going to be slowing down the heart rate. Are these going to be used for ventricular arrhythmias? They do anything to actual conduction in the ventricles? Not really, right? They're only really going to be affecting that nodal tissue. So these are good for supraventricular arrhythmias. And so, for instance, you can have this is going to be an example of what we call rate control, where if a patient has AFib or a flutter, this is going to prevent that really fast rate from getting down into the ventricles, but you're going to find that it doesn't necessarily do anything for the actual atrial arrhythmia, okay? So it's not going to convert them back to normal sinus, but it can help them make sure the ventricles are pumping at a nice controlled sort of rate there, right? So it's a rate control. And so, again, we all know all the side effects we have to worry about. If you have a patient with reactive airway disease, what do you have to think about using? Like a beta-1 selective agent, like what? Atenolol, what else? Metoprolol, right? Bisoprolol, any of those are good cardio-selective agents there. Just keep in mind those are what you'd use depending on the patient, kind of what they're presenting with. Again, propranolol specifically has some membrane stabilizing effects, which is nice because it kind of helps to also work as an antiarrhythmic to some degree. But again, supraventricular arrhythmias are the big place where this is going to be working, right? Again, we know all the toxicities, we know the adverse effects, the contraindications, so you know who to be careful with this in. If they have heart failure, may not be a good drug to all of a sudden blast them with, right? It's something you have to go really low and slow with in some of those cases there. Metoprolol we know would be a good option as a beta-1 selective agent there. Actually, a really good one you can use in the hospitals is called esmolol. Esmolol is called Brevibloc, and actually has a very short-acting drug, and we give it via continuous infusion to try to keep the rate under control. And you can really gently titrate that one nicely because it's such a short half-life. It gets to steady state very quickly, and so you can end up working with that pretty well. Okay, so getting into class 3 antiarrhythmics. There's only a couple we'll talk about in this category here, but this is going to be a couple of new drugs we'll talk about. But basically what this is going to do specifically is blocking those potassium channels. So what is this going to do to, say, for instance, your QRS interval, you think? Would it do anything to that? Not really, because it doesn't really do much to your sodium channels. It doesn't do anything to sodium channels. However, what do you think it does to your QT interval? It's going to prolong that, because that refractory period is being prolonged in those cases there. So again, what do you think is going to be a big risk with these drugs? Or SODs, right? Absolutely. So you got to be really careful with that. Again, prolonged the refractory period, hopefully interrupting any of those arrhythmias. These are also going to be good for both atrial and ventricular arrhythmias. And in fact, one of these drugs here, amiodarone, is kind of like your go-to antiarrhythmic for sort of life-threatening code sort of situations here, right? So if you go to a code cart, or to walk over to the hospital and go grab a code cart, I guarantee you'd find some amiodarone in there. That's kind of our go-to sort of antiarrhythmic during code situations. But anyway, so this is, some patients will only get this via the IV route, but a lot of patients get converted over into oral therapy, and they can be on this long term. This actually is an analog of thyroid hormone, which is important because we'll talk about how that can cause some side effects here in just a moment. Big thing to note with amiodarone is it has a super long half-life, anywhere between 26 to 107 days, right? Average of 40 days. That means how long does it take to get to steady state? Say 4 to 5 half-lives. 5 half-lives times 40 days, it could take 200 days to get to steady state. So I say, okay, I got my patient here who's actively coding, they're in VFib, I need to convert them back over. I say, okay, just wait 200 days and we'll come back and see how you're doing. They're gonna be dead by then, right? So what do you do to get around that? Loading doses, absolutely. So we always give loading doses for amiodarone in sort of those life-threatening situations. You start them off with a loading dose, get them under control, and then you usually put them on a drip afterwards to keep that rate controlled, and then switch them over to oral therapy eventually. However, what do you think this means in terms of, say a patient's been at steady state, they've been on the drug for, say, a year now. What do you think it means once they stop taking it? What does that mean in terms of the drug getting out of the body? It's going to take a long time, right? So even if they're having toxicities from it, they can still stick around for quite some time. And that'll make sense when we talk about some of the toxicities we see in the long term. Just know that this is a, oh, yes, sir.
Is it important to like have amiodarone in the past, like maybe half a year? Is that going to affect how you dose them? Yeah.
Not necessarily. If they're like, especially in like a life-threatening situation, you're still just going to hit them with the normal dosing. You know, hit them like 300 of amio or something like that, and then kind of go from there. So again, this has some other actions as well. The main thing is the potassium blocking effects. We can see here it can affect things like calcium channels and beta blockers, beta cells and things like that. So a lot of different activities you're going to see here. But overall, the potassium channel blocking is the main thing. But you do see a lot of toxicity seen with this, especially in the long term. So hypotension, could be a thing you can see, especially if you're using it in more of an acute situation. I'm hitting them with a big IV dose, you can certainly see hypotension. But long term, what are some of the issues you can see? Well, things like pulmonary fibrosis, right? This can be potentially fatal in some cases, so you got to really watch that. Make sure you're monitoring your PFTs over the long term. You see things like muscle weakness. Actually, another thing you see here is this blue-gray skin discoloration, right? So you can tell someone who's been on amiodarone for years and years, because they typically have kind of a more ashen sort of complexion there, right? You guys heard like, what's an ashen complexion mean? You heard that term? We just had a sim the other day, and a lot of my other students didn't know what the term ashen meant either. So if you think of ash is what kind of color? Kind of gray, right? So they have kind of a grayish sort of color to them. Is that usually a good thing? Is that usually indicative of vitality in life? No. So someone who looks ashen, not a great thing, right? Now it's different from calling someone ashy, right? You don't want to do that either. It's kind of mean. But ashen, usually not a great indicator. But they can have that sort of discoloration. Other things, you see some corneal deposits, so some visual changes can occur there. And because it's an analog of thyroid hormone, you can actually either find hypo or hyperthyroidism as a result of amio. It's very unpredictable in terms of what it's going to cost for your patients there. Okay. Also inhibits a lot of CYP enzymes, things like 3A4 and 2C9, 2D6, so a lot of different drugs that interact with this. So you got to be careful with amio for those patients there. Okay. But back in the day, if you were to look at like your ACLS guidelines, it used to be lidocaine was recommended first line in a lot of cases. Nowadays, amio has really kind of supplanted that. That's kind of your go-to pharmacologic therapy for arrhythmias in code situations. Kind of a more pure sort of acting drug here is going to be difetilide or Digoxin. This is just a pure potassium channel blocker, so it doesn't have all the other ancillary stuff that amio does. Now again, this can be used to maintain normal rhythm in, say, atrial fibrillation, but it's really limited to patients, to providers with specialized training. So it's not going to be your run-of-the-mill family practice person is going to be prescribing this. It's going to be something that works in cardiology specifically, because it is so dangerous in the wrong hands, right? So if you have someone whose potassium is off, their magnesium is off, anything like that, you can very easily put them into torsades, right? So this is why you have to be really careful with this drug. If they have renal dysfunction, because it's eliminating the kidneys, that can lead them to accumulate the drug, that can lead them to torsades as well. So really big risk drug, but it can be very effective for some of those patients who are, more low risk for that. And then actually sotalol here, and you may think I have my slides out of order, right? Because sotalol is what kind of drug? It's a beta blocker, but it actually has potassium channel blocking ability as well. So sotalol is kind of the exception to the rule, and we'll consider that to be a class 3 antiarrhythmic as well, because it does block some potassium channels in there. So very similar action, similar risk you would see with the other class 3s. Okay. Again, be careful because this is another non-selective beta blocker, so bronchospasm is going to be a risk here, right? Then we have our class 4 antiarrhythmics. Remember what two drugs fit into this category? Verapamil and diltiazem, just the non-DHPs are going to be here. And you could use these similar to how you would use the beta blockers in terms of treating arrhythmias. So for instance, if I have someone who's in SVT, which stands for what? Supraventricular tachycardia, right? I can go ahead and say, for instance, they were not able to tolerate, say, a beta blocker, I can use something like verapamil and diltiazem as an alternative, and that can be a very easy agent to use for those patients there as an alternative. Maybe they have asthma, I can go ahead and use this instead. Just be aware the negative inotropy sort of effects. You have to be careful with that. Remember all the other side effects, contraindications we've mentioned with these two drugs as well. Okay. Again, most often you're going to see this used like IV forms for, say, supraventricular tachycardia. We've got some birds that are like kind of hanging out. He was very interested about the calcium channel blockers, so you wanted to learn about that too. Anyway, so again, we know the side effects we have to worry about. Remember any CYP interactions to worry about with verapamil diltiazem? Yes, 3A4 inhibition, right? So be very careful from that standpoint. Now, the last thing I want to finish off with is going to be the couple of miscellaneous antiarrhythmics. If you don't mind me going over a few minutes. Again, I was late, but we'll deal with it. Just put it on my evals. Not cognizant of our time. Do you guys have anything after me? Perfect. You guys have the rest of Friday off? Yeah, it's slackers anyway. Okay. All right. So I want to talk about a couple of drugs here. So adenosine's the first one. Has anyone ever seen adenosine given? If you get the opportunity, adenosine is one of the coolest drugs you can ever give to a patient acutely. So this is going to be used to treat supraventricular tachycardia. So if a patient's coming in, their heart rate's sitting at like 180, 200, this can be used to very effectively basically reset the heart. So kind of like if your computer's not working very well, what do? Turn it off, turn it back on again. This drug does the same thing to the heart essentially. And so you can actually see that. Basically, it is kind of like the emergency brake on your car a little bit. It basically kind of stops everything. And so you'll give this to a patient, they'll have a continuous EKG running on them when you give it, and you'll see the patient flatline for like a couple seconds. Patients will be conscious, they'll still be awake, but they'll flatline for a couple of seconds, and then hopefully they'll go right back into normal sinus rhythm. More often than not, they'll either go into normal sinus or they'll go back into the SVT, right? So that's normally what you're going to find there. The interesting thing with this drug is how you administer as well. It's an extremely short half-life, about 10 seconds, right? So this means that if you give it too slowly, and say for instance you have a patient coming into the ER, they're not going to have nice central access where the line's going to dump out right into the vena cava. You're going to have a peripheral line, and so if you give this too slow, by the time the drug gets to the heart, it's already degraded. It's not going to work. So what we have to do is kind of make this contraption where you guys are familiar with like a three-way stopcock. Remember chemistry back in general chemistry? So I know all these things end up coming back at some point, right? So basically, it's like having a three-way thing here, and then you have like a little knob that kind of will set where the flow, you don't want the flow to go. This is a horrible drawing, but you'll get the. Go look up pictures afterward, and you'll see kind of what I'm getting at. Anyway, so what you're going to find here is you're going to have basically the adenosine going on to one. You have the adenosine hooking up to this part of the port. You're going to have the saline flush hooked up to this, and then this goes to the patient. Okay, so the point is you want to slam in that adenosine, and then you flush it behind it very quickly, and that ensures you're going to be flushing all that drug right to the heart. Because frequently what I see is that patients or whoever sets this up will not give it quickly enough, and then they'll say, well, the drug didn't work, patient's still in SVT, and really they just didn't give it fast enough. And so then you'll double your dose, and then all of a sudden that will work because more of the drug actually got to the heart in those cases there. The most frequent mistake I see people run into is they don't know where to point this knob at, and that will, if it's pointing in any one direction, it stops flow in that direction. So they'll either have it to where the adenosine can't flow in, or it's not going to the patient, and it screws up the whole thing. So make sure you know how to use your stopcocks, because again, in those situations, it can feel very rushed and very frantic and emergent, but you got to take a step back and slow down, make sure you're going to do things properly, right? Because when you're in a rush, that's how you do things incorrectly, right? And with some you're like, oh, what am I doing? Actually, I just saw a couple of my students who are on rotation. One's doing a general surgery rotation at Nemours, and they're like, I was so happy that I had that surgical mask on because they were doing a circumcision, and my face, if the parents could have seen my face at the time, they would have been, just horrified, because I was like, but that's why you keep the surgical mask on. But anyway, so you set up this contraption, you slam the drug in, and you actually will look and you'll see the patient flatline for a couple of seconds, and then they'll come right back. And so here we'll use it most often for paroxysmal supraventricular tachycardia, and some of the toxicities you can see with that is a lot of flushing, the shortness of breath, and we'll get a lot of burning sensation in the chest as that drug's going in. So again, that's a very cool drug. You'll see that used in the emergency department probably most frequently. All right, Digoxin also kind of fits into this miscellaneous antiarrhythmic category. Again, you may see this being used more so in like AFib, A-flutter sort of situations here. Again, be careful because it can induce heart block, it can cause hyperkalemia. All the stuff that we talked about in CHF applies here, just we're using it for a little bit different context there. Right. Again, watch out for the toxicities you're going to see with that, especially that renal dysfunction. Not going to be able to clear it very well, so you got to be careful with that. And especially avoid using it along with a beta blocker or calcium channel blocker. Be very cautious because they can all have cardiodepressant effects, AV block, bradycardia very likely to occur. Okay. And then finally, magnesium. What is magnesium used for? Torsades. This is the treatment of choice. If you get a board style question and you get this wrong, I disown you as a student. Magnesium sulfate is a treatment of choice for torsades, right? So you give that same code card right next to the amio, probably going to find some magnesium sulfate along with that. So give them 2 grams, and hopefully it'll end up treating that. Basic things you want to be careful though with magnesium. We talked about magnesium previously and used for what disease state? Did we talk about an asthma at all? Like status asthmaticus potentially? We mentioned that at all? Okay, so anyway, so another situation you may use this is if you're having like really severe asthma attacks. It's called status asthmaticus. You can sometimes use magnesium. Kind of works as a bronchodilator a little bit. But basically, the thing you want to be careful of, this is a smooth muscle relaxer. It actually kind of works like a calcium channel blocker to some degree. So you will see things like flushing, headache, and you can't see hypotension. So you got to be really careful with that. Make sure patients are well tanked up with fluids. And in fact, if you were to order this, say, in ER over at Nemours, we have this as a linked order between a saline bolus. Anyone know the dose for saline bolus is? I talked to this. 20 mLs per kilo plus the magnesiums. That way they make sure that they're intravascularly repleted with fluid, so that way even if they get some vasodilation, their blood pressure doesn't bottom out. So that's something you want to be careful of, okay? So that's it for the antiarrhythmics. I know that's quick, but again, just take away the big key things there. Like, again, if I say a patient comes in with tinnitus, blurred vision, in nystagmus, you'd be like, oh yeah, that sounds like quinidine toxicity, right? You should be able to kind of key in on those things that are very unique to those particular drugs, right? Know what kind of arrhythmias these are good to treat, right? So I'm not going to get super specific in, saying, oh, they have, like torsades, you should know it's magnesium, like I just mentioned there. But if I say come in like PAT or something like that, like I'm not getting that specific. But generally, know, is a drug going to be good for treating ventricular, atrial arrhythmias, etc. Right? So if I say amio, that's going to be good for which ones? Amiodarone, it's class 3 antiarrhythmic. It's good for both atrial and ventricular arrhythmias. Say it's a beta blocker, it's only good for atrial arrhythmias, supraventricular arrhythmias, right? So those are kind of the key things I want you to take away from that. All right, if nothing else, let me see if there's any questions on the board real quick. Definitely discarding that drawing. Okay, quick joke. How do you handle metronidazole? I don't know. How do you? Flagellally? Like, is it very flagell? Oh, careful because it's flagell. Okay, there you go. The answer is right there. All right. When would you use lidocaine to treat MI? And first line is nitroglycerin is a commonly used or a go-to. So remember, they're being used for different purposes, right? What is nitro being used for in the case of MI? Vasodilate, so coronary vasodilation, right? So hopefully it's going to be relieving angina, or if they're hypertensive, you can give nitroglycerin to drop that blood pressure. Does it do anything to treat an arrhythmia they're developing because of an MI? No, that's where the lidocaine comes into play, right? It can be useful for treating that ischemic tissue that may be generating that arrhythmia. So that's where you'd use it for that purpose there. And then is supraventricular arrhythmia the same as atrial? Essentially, yeah. So again, just depending on where that arrhythmia is generated at, if it's above the ventricles, most of the time it's going to be like an atrial arrhythmia. I'm sure if you talk to like an electrophysiologist, maybe they'll tell you something slightly different. But for my broad strokes purposes, that's what I'm referring to. Okay. Any other questions? That was pretty good. I got that joke. I didn't even read the punchline yet, so not bad. Okay, I will see you guys next time. Thanks for sticking with me.